So, shall we begin? A warm evening to all. I would like to welcome you all to the online sessions of Anahata 2023, Unleashing the Zeal Within, National Seminar on Exploration of Respiratory Ailments through Ayurvedic Perspectives. Participants can raise their queries, if any, in the chat box. The questions regarding the topic will be answered in the Q&A session following the presentation. Now, let's move on to the last online session of Anahata 2023 National Seminar on Exploration of Respiratory Ailments through Ayurvedic Perspectives. Tonight, we are at the privilege of having the very esteemed Dr. Muralidhara Sharma for the presentation on the topic Ayurvedic Management of Respiratory Disorders. A living legend, a well-known symbol of simplicity, dedication, and passion, popularly known as the present-day Sushruta, Dr. Muralidhara Sharma, Professor Emeritus, SCM College of Ayurveda, Udupi. He had his UG from STM College, Udupi, and PG in Shalyatantra from the prestigious Banaras Hindu University in the year 1983. Later, he joined as a lecturer in his mother institution, STM College, Udupi, and played a pivotal role in the development of the institution and was the key person in getting NABH accreditation for the same. Being an ardent follower and admirer of Acharya Sushruta, Sir is a leading surgeon and possesses the credentials of treating the highest number of patients at the hospital and his clinic, and his unique specialty lies in the conservative management of surgical cases. With nearly 4 decades of clinical and teaching experience, he has mentored hundreds of students, both UG and PG, and plays a role model for many. He has spoken in all vital forums of Ayurveda and received several prestigious recognitions. And his tagline says, "A good surgeon is the one who knows how to operate. A better surgeon is the one who knows when to operate. But the best surgeon is the one who knows when not to operate." Now, let's invite a very esteemed faculty, Dr. Muralidhara Sharma, sir, for the most awaited session on the topic Ayurvedic Management of Respiratory Disorders. Sir, please.
Thank you. Thank you. I hope I am audible and the screen is visible. Whether I am
Yes, sir,
audible
you're audible.
and the screen is visible or not?
Yes, sir, the screen is visible.
Okay, then let me start with the head. And thank you for the introduction. and thank you for the opportunity to be with the young minds of Ayurveda. Now, the whole question is about Ayurvedic practice and the diseases of the respiratory system. There are certain basic doubts in budding Ayurvedic doctors like the younger generation who have a question like whether Ayurvedic practice can be sustained or not in the present days competitive world. And they have always a doubt like whether the contemporary system of medicine has to be followed, has to be studied, or not, to which extent it has to be studied, and how it has to be used in the clinical practice, and so on. So there are huge numbers of such confusing questions. Now I'm trying to give a solution. Maybe it's not a permanent, ultimate solution, but I'm giving my view on these issues, how to make use of the contemporary system of medicine and maintain a core Ayurvedic practice which can reach to the system or which can reach to the society, and particularly the middle class and the lower class of the society, so that the people, suffering people, can be helped as such. That's the whole theme of that presentation. Of course, at the same time, I will be trying to deal with how I deal with the respiratory system disorders as such. Now, for a successful Ayurvedic practice, the basic issue is, the first is you have to have a fair knowledge of the disease process. And for that disease, study of the disease process, it's not necessary that you have to limit only to the samhitas. You may have to go beyond that. And a perfect assessment of the disease and its status stage is one of the important step, the first step to get into the successful practice. That's what Charaka has said, Rogamada Upariksheta, Tato Anantaram Aushavam, Tasa Karma Bishak Paschat Jnana Purvam Samachareta. The first and foremost is to know about the disease, the stage in which it has been done, which is presented, and what can be done, and to predict the prognosis. Then only the medicines. The medicines or the drugs, they come the secondary. Medicines, of course, they are needed, but you may have a few limited medicines. With that, you can reach to a larger number of the diseases and larger number of the people. And this is exactly what's Darshanaddeha Avaitaha. Tatsamya Gopalakshayat Vyadhya Avastha. The most important part of the management, this clinical practice, is Vyadhyavastha Vibhagaha. And then you have to plan the management, and that planning the management to be based upon the yukti, matra kalashaya yukti, siddhi yukto pratishthita, tisthati pariyuktijna. So yuktijna, that's the perfect combination of the drug at the right time, at the right stage of the disease, is the most important part of the treatment. Now, how to do that? I am just trying to give an example of how I deal with these issues. The whole issue is based upon a thorough clinical examination and diagnosis, which is the first step. You may have to make use of all the currently available investigations as necessary. And I always say that if you have to be a successful Ayurvedic practitioner, you should be more modern than a modern doctor. There is also another issue. Another issue is of the social obligation. Like, a patient should not suffer because of your allegiance to a system. So patient should always get the best. And you also have to have a clear-cut impression of what next can occur to the patient. And this has to be predicted, important. Now, to have this, and another important issue is, most of the times when the patient comes to a physician, particularly Ayurvedic physician, the patient would have lots of previous diagnoses. Most of the times, majority of the patients who come to Ayurvedic practitioner would be those patients who have tried elsewhere, and there would be many diagnosis process done already, and there can be a lot of the information which can be misleading. So for the first and foremost is, you do not depend upon the previous reports. Examine the patient, have an impression of your own on the patient, and then look at all the previous records, and then the whole approach of the selection of the drug would be based upon dosha assessment. But prediction of the prognosis and the course of the disease is based upon the other information which is available. Maybe you may make use of the contemporary system of medicine. Now, this is the basic theme of the whole clinical practice as I approach. Now, with this background, I start with the respiratory disease conditions. starting with the common simple conditions and then trying to cover up as many as possible. It's never possible to complete or have a coverage of all the diseases, but I'll try to make it as simple as possible and most common disease conditions as far as possible. I'll try to deal with the most common physical conditions as such. Starting with the most common clinical condition related to the respiratory system, which everyone would have experienced at one or other stage of the life, is simple what we call as a cold and fever or rhinitis, viral infections, which can be seasonal, which can be even presented as a sort of endemic disorders and so on. Simple mild changes which occur, which is often called as cold as such, which is a pratishyaya. And I would consider this as simply a simple pratishyaya, as the lakshanas are mentioned in the Samhita. Anashyate yaste vidhupyateja prakriti shushya vichapinasa navetyo gandharasamshajantu justam evasya tam apinasena. This is the typical presentation which you see, where the duration is short and patient may have a mild fever as such, and the nasal discharges, thin nasal discharges are irritation as such, mild symptoms, which is common. And majority of these diseases can be managed without any medications. The usual common statement like a cold can be managed with the medicines for 1 week and without medicines by 7 days. So that's exactly the thing. So all that you have to do is take moderate rest and take care in the diet, have some light food, and do not expose to the cold. With that, it can be managed. So I generally do not advise medicines, but if at all the patient, now when you go into the practice, when you are in a clinical practice, it may not be possible to say that you don't take any medicines as such. And in that condition, the findings, there are no other pathological findings. All the other investigations have been normal. The only findings which you see would be the nasal mucosa is slightly congested. You don't need any specific investigational tool. A simple torch would be enough. A simple focusing torch would be enough. Look at the nasal mucosa. You may have some spots of congestion, maybe at times slight discharges over there. And this is exactly, I would consider this as either kapha jwara or the other way. And in these conditions, ideally, there would be no medicines. But if the patient demands for that, my usual prescription would be Mrityunjaya Rasa and Arogyavardhini and Amrita for 2 days. By 2 days, it will be fine. This is exactly what kapha-jwara lakshanas are there. Gauravam, Shitam, Uklesha, Romaharsha, Atinidrita, Srotorodha, Ruga, Alpatpu, Alparupu, Praseka, Madhurasita, the not Tushnagata, not very high fever. These are the typical symptoms of kapha-jwara, and the treatment is relatively minimal and virtually there are, in reality, there is no need of any medical management. It's only the diet which could be enough. But if at all there is a need for medicine, and in the practical clinical field, you cannot just manage without medicines. So my prescription would be Mrityunjaya Arogyavardhini Amrita just for 1 or 2 days, short duration. But the same, there could be a patient who have the similar symptoms in the beginning and it may progress to the next stage. Or at times it could be like the patient may start with the more these discharging or more severe symptoms, and that the patient would have a real discharges, which also would have a post-nasal drip, that there would be irritation in the throat and the discharges would be entering in the throat, and hence it results in what we call as a sneezing. The sneezing reflexes presented. Congestion would be more in that condition. If you look at the nasal mucosa will be more congested. That hyperemia is very much marked as such, and you may even see the fluid, thin fluid presented over there. Drops of fluid may be seen, and the patient may have typical history of the postnasal drip, where the patient may have the irritation in the throat and sneezing, where the typical symptoms would be of the pratishyaya lakshanas, again pratishyaya lakshanas with more of kapha lakshana, shiro gurutvam, kshavatoha pravartanam, tatra angamagdha prahisvaromata, sorry, more of pitta lakshanas, and upadravashchapya pade pratham vidahananam pratishyaya purasara, it's a pratishyaya upadrava, which could be seen. And I would consider this as a pitta kapha stage, where there would be involvement of the pitta kapha. That again, the basic protocol of the treatment, my prescription would be same, Mrityunjaya Arogyavardhini Amrita, but I would be advising the patient to take the medicines for 4 days. The duration of the treatment would be more. And in these patients, simple diet and rest may not be enough to manage the conditions. Of course, it will be good. You have to have that restrictions of the diet and exercise. That restriction is necessary, but even that alone may not be enough. And in that conditions, my prescription would be Mrityunjaya Arogya Arjuni Amrita for 4 days. The duration is enhanced. Now, you may have another set of the patients, or maybe the same patients who turn out maybe after a few days, or maybe more severe presentation of the similar issue. Rhinitis with the postnasal drip, second phase. Now, that stage 1 and stage 2 is my own nomenclature. Of course, no textbook would say this, but I would consider this as a condition where you will have more thick discharges. Discharges are thick and slimy. They may not flow easily, but postnasal drip irritation will be there, and it may even present with mild cough irritation of the throat and may have even the cough as such. And that's exactly Anandha Pihita Nasa Talustrava Pravartini. The Nasa would be Anandha blockage, feeling of the blockage, and Galatalu Vostashoshasta. That's exactly the feature. And even that may affect the voice, and patient may have even that what we call as a temporal headache, the headache over the area. That's Nistodaha Shankhayohata Sarvabhaghatasta. The voice also may become slightly hoarse. You may make out exactly like the voice is somewhat altered. And this is the situation where I would consider it as a Kshabatu. Kshabatu, Granashide, Marmani, Sambrudiste, Anilaha, Nasikayani. Now, in these conditions, the treatment may prescription because of Vata Kapha involvement. I will consider this as Vata Kapha involvement. And the findings should be when you look at the nasal mucosa, you can see these slimy, thick discharges, which may be fibrinous also. And or maybe in children, small children, you may have that sticking over the nostril. You may see that thick, dry nose as such. And the main prescription will be either Mrityunjaya or Tribhunakirti. If the patient has more Kapha Lakshanas, I would prefer Tribhunakirti Rasa. If it is more Vata Lakshanas, it's a Mrityunjaya Rasa. And Lagusutta Shekhara, sorry, there is a spelling error. It's not Shekhara, it's Lagusutta Shekhara. And Amsarista, the duration of the treatment would be 2 weeks. That's again important. When we exactly say to the patient, like, you need to have this much of the duration of the treatment, patient would accept the treatment, and then the total perception of the patient to the treatment would be better. And this is exactly how you can predict the outcome as well. Now, the same or similar conditions which become chronic, where either it could be due to the continuous exposure to the cold or improper treatment, and very often a patient who starts the antibiotic treatment in the beginning where there is not much of a real need for that, such a patient may develop a situation where the sputum or the discharges may fill into the nose and these sinuses, and the patient may have a chronic sinusitis or rhinitis, where the headache becomes more severe. The nasal discharges may persist. Clinical examination may show the tenderness over the paranasal sinuses or the frontal sinuses, and the discharges are quite conspicuous, thick as such. And this is a situation where I would consider this as the more severe stages of the Pitta or Tridoshida variety of the Pinasa. Ushnaha, Sapitaka, Srabaha, Grana, Savadipaitike. It's a typical Pitta due to the Pitta involvement. There would be the thick discharges present over there, and it may even affect the systemic functions, like the appetite would be affected. Because of the headache, the patient may have this loss of sleep and so on. Often the total physical activity also would be affected. And that's exactly the typical features which you see in case of the Dvandaja or Tridoshya variety of the Jara acid. And in these conditions, my treatment would be Mrityunjaya Sutshekara, Pipalyasava or Somasava. Pipalyasava, when the patient has more sputum coming through. Somasava is that sputum is dry and facilitate that expulsion. And Anutailanasya also is suggested. And the duration of the treatment would be for a longer period, like 3 weeks. So we cannot expect the patient to have a relief in 1 or 2 days, and minimum duration of 3 weeks treatment would be required in that condition. Now, the same chronic sinusitis again, which is more pronounced, and the patient may have persistent symptoms for years together. You will have such patients who have the similar symptoms which are persisting for years together, or repeated episodes of such conditions, and quite severe tenderness over there. in the sinus area. Of course, the other investigations like X-rays also may be necessary. CT scan or X-rays also may show that evidence of sinusitis. But a simple nasal examination can also help you to make out that there is a significant congestion over the nasal mucosa, and then these thick discharges sticking over the nasal mucosa can be seen, and that's exactly what you see the Brahmshatu stage as such. The Brahmshatu stage, the clinical symptoms mentioned in the Samhita are Prabhrashate Nasikayu Yascha Sandraha Vidagdaha Labanaha Kapas. The patient would have a sputum which is salty in nature. That's exactly the symptoms which we will see. And perhaps Sanchita Murdhani, because of the collection in the sinuses, which can be proved that Murdha Sanchayana can be proved with an X-ray or CT scan if necessary. And this is exactly the Brahmshat. And these are the conditions where the modern medicines often may not produce sufficient results, and the patient would come to Ayurvedic treatment. Majority of the patients who come to Ayurvedic treatment prefer Ayurvedic treatment after trying the other treatment are at this stage as such. And in these conditions, my usual prescription would be Mrityunjaya Rasa Sudhshekara Anutelanasya, same as earlier, but the duration would be for minimum 8 weeks. And I would consider this as a Kapha Pittaja or Tridosha. Then comes the allergic rhinitis. The patients may have another variety of the presentation. Either it may be a sequence of the similar issues or maybe slightly a variant. It could be a parallel entry into the series of these respiratory conditions. Patient may have the exposure to the allergy, which can present with the typical episodes of sneezing, discharges from the nose. That's a Bhutta Pradikshaya, Ekasmat Universate. Sudden episodes of the discharges from the nose, sneezing, and so on. And the patient would have all the other signs of PNSA, the sputum coming through, or sneezing and discharges, nasal, post-nasal drip, all that symptoms could occur. Or it could be Ajasram Acham Salila Prakasham Yasya Uvranam Savadiha Nasa. The patient may have a continuous persistent discharges for years or months together. Either that could be periodic episodes of due to the exposure to the cold or exposure to certain specific substances that the patient may have that respiratory symptoms, or it could be like some of the patients may have a continuous symptoms. Both of them are the allergic rhinitis conditions, and this is exactly Rasa Parisrava, particularly Ratro Visheshana Hitam Vikaram. The exposure to the cold or cold seasons would aggravate that condition. That's the typical feature of the Nasa Parisrava. And when you look at the nasal mucosa, the nasal mucosa is shiny, it's mildly inflamed, and more than the reddish inflammation, there will be whitish deposits over there, and the whole surface looks very shiny. Discharges can be seen over the area, and the mucosal surface would also be bulged, swollen, bulged appearance. That whole thing looks as if tense, that a tense mucosa due to the collection of the fluid in the mucosal area is the same situation. The same may extend to become a nasal polyp in the next stage. Now, in these allergic rhinitis conditions, my treatment would be particularly when the patient has a prolonged history, and most of these patients would have prolonged history. That's in such conditions, my basic management would be Mrityunjaya Rasa Lagusutta Shekara. Again, there is a spelling error. It's a Lagusutta Shekara, and Amsarista and Anutelanasya. Duration would be minimum for 3 months. But still, there could be a few of the patients who may have these symptoms which tend to either persist or may recur. And recurrence in these conditions are quite common. And hence, these conditions, if there is either a possibility of recurrence or you have to prevent the recurrence, my usual prescription suggestion would be if the patient has more prominent Tridosha Lakshanas, I would be advising Virechana or Vamana once the acute episode has subsided, and maybe at times it could be repeated. The Virechana or Vamana may have to be repeated so that the recurrence can be prevented. A Kaphaja Lakshanas, patients who have just exposure to the cold or exposure to a specific substance producing these kinds of conditions, once the acute phase is subsided, to prevent the episodes, my preference will be either Haridra Khanda or Chavanaprasha, even for a long duration, maybe 5 months, 6 months, or maybe as long as the patient wishes. And a very severe Nasa Parisrava, patients who have a very severe symptoms, which become resistant to the usual treatment, In that condition, I would be adding Makarapere 1 gram to Lagusudhashekara, and 1 gram per week is given along with the Lagusudhashekara powder as our Lagusudha Mishrana powder, which also can be given for a long duration, which can prevent the recurrences and which can manage these allergic rhinitis conditions better than others. Now, another variant of the similar issue is the hemorrhagic rhinitis. Of course, incidence of the hemorrhagic rhinitis is not so common. It's rare as such, where the patient may have blood bleeding from the nasal mucosa. And often what the patient would have is the patient would have that typical history of sneezing and nasal congestion. And when the patient squeezes out, instead of the phlegm coming through, you may have even traces of the blood, or at times it could be a massive, significant amount of the blood also can come through. But luckily, such incidences are not so common, rare. Rarely you get across that, and that's exactly the features of Raktaja Pradishaya, where Raktasravaha Pravastave, Tamrakshashta Bhavidyandu, Guru Khata Prapedita. There is always a possibility of the systemic environment. And another characteristic feature is Durgandha Kuchasaha. The patient, the smell of the blood as well as other foul smell may be seen. And in these patients also, another characteristic feature is Gandhana Bheti. The patient would have a impaired sensation, perception of the smell sensation. These are the typical features of hemorrhagic rhinitis. Though they are rare, and I would be treating such patients with the Chudeshekara, Kamaduka, and Draksharista or Ushirasava due to the involvement of Pitta in the Rakta, and Anukalarasya, the duration average would be around 3 weeks. Then another of the consequence of a similar issue, progressive conditions, where the patient may have any of these previous histories and then it tends to become persistent. The patient may have atrophic rhinitis, another of the outcome of a repeated exposure to the cold and so on. Atrophic rhinitis, when you look at the nasal mucosa, it's very characteristic. The nasal mucosa will be very bald. That shining appearance is lost. It looks somewhat dull. That whitish color is seen. Either it could be uniform, smooth white, or you may have this puckered appearance. Appearance may where there could be some spots like appearance. And the very characteristic in these conditions would be patient would not have the smell sensation properly, loss of sensation, and nishvasa uchasa durgandhyas. Foul smell is the other feature. And prakrityati punarnasa punascha parishushati, that dryness of the nasal mucosa. Patient would complain of the dryness of the nasal mucosa with the repeated episodes of the discharges over there. And muhur anashate chapi muhur vibrite tatha. At times the patient may feel better, at times that could be a feeling of the obstruction. That's exactly the typical feature of atrophic rhinitis, and that's exactly what you see in the Samhitas, Pratishaya. And in these conditions, the outcome is poor. Prognosis is always poor. Majority of the patients would not have a satisfactory improvement. There could be only a temporary relief or maybe marginal relief. And my treatment would be a Plutinja, Sushekara, Godanti, and Ayurvedic Churna. Considering this as a variation where the Amashaya has to be treated. The Amashaya Thavyadi, the involvement of the Amashaya in the respiratory disorders, starts at this level, and I would consider this as a situation where you need that treatment. And another option of the treatment which can produce some significant change in the outcome is Virechana. But most of the times, the outcome is not satisfactory. A complete cure in atrophic rhinitis is hardly possible. Rarely a few of the patients may have satisfactory relief, but most of the times, patient may have a better relief. But one thing is certain, the relief given by these prescriptions is much better than whatever the contemporary system can produce as such. Now, this is one sequence of the respiratory environment, the upper respiratory environment. Another consequence of the upper respiratory environment is that allergic rhinitis, starting with that accumulation of the fluid in the submucosal area, can result in a polyp formation. That could be another of the consequence. This is another outcome which can occur in case of the respiratory conditions. And these nasal polyp formations are exactly either the nasarshas or nasarbuddha and so on. The variations of these nasarshas is either it could be Tridoshaja or it could be the Ekadoshaja, and or it could be the Arbuda. Now, in all these conditions, as the patient presents with this polyp, The most important clinical symptom will be that the patient would have a nasal obstruction along with all the previous history, any of those previous history of repeated episodes of the nasal discharges and so on. And the identification of the polyps also is a relatively simple job. All that you have to have a focus, light, and then have a careful look at the nasal mucosa. And in these conditions, the nasa pratinaha, the important is a nasal polyp needs a more accurate clinical assessment. Particularly nasal polyp occurring in a patient with the middle age or beyond, you have to be extremely careful. It could be a sign of a tumor pathology. And hence, in such conditions, a biopsy is needed. Particularly if the nasal mucosa swelling is having a rough surface, has a history of bleeding, you need to have a biopsy. You cannot just avoid that. But surgical treatment for a simple nasal polyp otherwise often fails, and in such conditions, the medical treatment would be enough. But hence, in a patient with nasal polyp, particularly in a middle age or beyond, the later half of the life, I would always go for the diagnostic investigations and preferably biopsy and confirmation and ruling out of the tumor pathologies. Whereas in the younger age, chances of the tumor formation are lesser, and particularly if the surface is smooth and the patient has a history of watery discharge, maybe it could be that the typical nasal polyp produces inflammatory conditions. So in these conditions, a simple clinical examination often may not be enough to confirm this, and there you need to have more detailed clinical approach. Once you have ruled out those tumor pathologies, I would consider this as nasa pratinaha, which is produced due to kaphavrata vyadhi. Kaphavrata vayu hugdana samnyaha yada sumarge vigunasthita syat ghanam motivata rogi nasa pratinaha iti pradishtaha. Nasa pratinaha is exactly that kind of a situation where the chronic respiratory irritation produces involvement of the kapha and vata, and this lesion is presented. And my prescription in such treatment would be Mrityunjaya, Trifala and Anutelanasya. And majority of these conditions are simply yapya. It's particularly a few of these conditions could be yapya, but important is our treatment can produce more satisfactory results. In younger age, and particularly those patients who are having a history of exposure to the irritant substances with allergy, they can be better treated, better cured as such. Lifestyle suggestions are essential in these conditions. But as I told earlier, a surgical intervention to rule out tumors like biopsy would be necessary, and you need to take a very careful approach there. Now, one more of the consequences, another possible outcome of this upper respiratory involvement would be either septic or atrophic changes, which is nasapaka, where the patient may have a septic pathology. The patient may have the clinical symptoms of a more purulent discharges and pain, headache, so on. The smell also would be foul smelling, and the patient may have a very prolonged history. Thanashidam tiktam arumshikuria desmin kare balavanshapaka. Tam nasika pakam nijivivaseta. Nasa paka is the such conditions as such. And even there could be very severe pus-like conditions, which also is described as putinasha. Doshehi vidagdehi talmule samatsigo yes samiranastu. Putinasha is where the upper respiratory terminae are involved, the proximal respiratory terminae are involved, and nasapaka is where the lower terminae are involved, where the pus is very clinical, visible clinically, whereas in case of the putinasha, it will be in the thalmula, upper part as such. Now, both these conditions, simply management with the Ayurvedic medicines may not be often enough because of the possibility of toxicity. Many of the patients may have high toxic symptoms as such, and I would always prefer to have a course of antibiotic to such patients. In all the other conditions, antibiotics are not necessary. I may prescribe the antibiotics myself, or I may suggest the patient to go to other system to get the treatment. Surgical exploration also may be needed. The patients may not be able to, simply may not be possible to manage with our treatment alone. So most of the times, either after surgical drainage, so preferably surgical drainage of the sinuses and an antibiotic course, and I may prescribe the treatment like Mrityunjaya, Tripurabhul, etc. The same as such. Now, another consequence, now one level low upper respiratory, nose, and the this nasal area covered. The next part is about the throat, and there is mainly the tonsils. The tonsillitis is another of the common condition where the respiratory tract is involved. Now, the tonsillitis conditions where there could be swelling in the throat area presented could be of many varieties. Conditionally, Tundikeri, Adhrusha. Now, these are suggestive of the different stages where Leshmasvyam Talumula Dirgashoko Bhatabasthi Prakasha. You'll have a swelling either like a elongated swelling or maybe globular swelling, which is presented at the base of the talu. And when it is presented with Trishna Kasa Shwasakata, where the patient would have other respiratory symptoms, it's called as congestionally, where the cough is the more. And Stula Toda when the swelling is quite visible, bigger swelling is visible, and it presents with the pain in the area, and it may have systemic features of fever, that's the Tundikeri. Whereas it is simply there is a bright reddish swelling, which can even result in suppurative conditions, comparatively painless, less painful, that's called as Adhusha, and the patient may have systemic symptoms like the Jwara, Rukha Jwara. That condition is Adhusha. Now, that's how Sushruta has graded these tonsillitis. Present day grading, which is based upon Brodsky, grading, is based upon the tonsil size. When the tonsils are limited to the fossa and they are not seen as bulging, it's called stage 1, where there is no involvement of the tonsillitis. When the tonsils occupy less than 25% of the oropharynx, the size is relatively smaller, it's the first degree. Second degree is when the tonsil occupies more than 25 to 50 degrees, then it's second degree. And the third degree is the tonsil when occupies from 50 to 70%, and the tonsil occupies more than 70% is called as a fourth degree. And based upon these criteria, often the suggestions of the treatment are suggested. The guideline, particularly the criteria for making the management, the standard protocol of the management is the Centaur criteria. Centaur criteria of managing, this is from the contemporary science, of making or planning the management of a tonsillitis would be tonsillitis scores are given. That's the modified Centaur score. Centaur score is if the patient has a high fever, then score 1. If the patient has cough or no cough, then again score 1. If the patient has cough, it will be 2 score. And swollen tender anterior cervical nodes, if there is cervical lymph nodes involved, then there is another score is added. And tonsillar exudate or swelling, another score. And age also is another criteria where you can have the scores. And the cumulative score, if the cumulative score is less than 3, there is no specific treatment suggested. It's a symptomatic management mentioned in the contemporary system, where the contemporary these practitioners would do. And if it's a score is more than 3, then it could be a infective pathology, and hence it's suggested like antimicrobial therapy is suggested. Whereas if the patient has other clinical complications like first discharge and so on, the antimicrobial therapy is done. Now, when I do the practice, my practice is I do not prefer this line of the treatment, but the same criteria is followed. And my criteria, my modifications there are, if the total count is less than 16,000, in that condition, I would be preferring Mrutyunjaya, Sekula, Gugul, Gandhaka, and Ampravista. Usually, the duration of the treatment is for 2 to 3 weeks. You don't need any other treatment, and warm water gargling or Tefalak gargling would be the other options of the treatment. Now, if the count is higher and if there is a sign of this swelling or signs like fever and so on, swelling is of grade 3 or beyond, grade 2 and beyond, I would be looking for ASO test, ASO anti-septalizing O test as such, because that ASO test is necessary to rule out the possibility of rheumatic pathology. Septococcal infections can result in the rheumatic arterial pathology, and that is needed to confirm that. And that ASO test is done as a rule in patients, particularly in children with the grade 2 or beyond tonsillitis. I would prefer to have anti-septalizing or titer test done. If it is positive and the patient also has tachycardia, then the treatment would be If that and the patient also has ASO positive sign, then in that condition, I would be preferring a course of antimicrobial therapy, and only after that antimicrobial therapy, usually either penicillin or penicillin derivatives are usually preferred there, and then mrithyunjaya is given as such. So this criteria is what I modify based upon the central criteria, and a large number of patients can manage it without this, but it's also important that a patient with the chronic recurrent tonsillitis, ASO titer has to be studied. And if the patient also has a tachycardia with the ASO titer, then too the patient has to have a management with antibiotics. If the total count is less than 16,000 and ASO negative, virtually no need of any other antibiotic therapy. With our medicine alone, the patient can be managed as such. Now, a tonsillitis again can have some more variations. Either it will be viral tonsillitis. Viral tonsillitis often is presented with the seasonal episodes like rainy season, cold season, winter season, etc., where the patient would have a smooth surface. The tonsils would have smooth surface. Along with the tonsillitis, the patient also would have nasal discharge. Now, in these conditions, it's not enough if you open and examine the nose. You have to open the mouth, also look at the tonsils. If the tonsils show that smooth surface shining, and if the patient has the nasal discharges, the other criteria of tonsillitis, central criteria is not necessary. You can manage with the same management of common cold like Mrithyunjaya. Then, if there is a history of bacterial tonsillitis, often it occurs due to some contamination. Patient would have a history of some exposure to infective diseases like, and when you look at the tonsils, you can see that pus pockets, rough surface, and the pus pockets could be seen as a patient also would have a clinical signs of fever, lymph nodes may be palpable, and ASO titer, of course, may also be positive in these conditions. And in these conditions, the center's protocol is necessary, where you may have to have a course of antibiotic and followed by glucocorticoid and triple gargling as the protocol of the treatment. Now, peritonsillar abscesses are the other conditions which rarely occur. It may not be very common, where the patient may have an abscess over there, quite huge swelling, and this is a condition is considered as asadhya, which may not be possible to manage with the Ayurvedic treatment alone. It's even a course of antibiotic also may not be enough. You may have to go for surgical intervention, drainage assets. And along with that, the patient may have more prominent rheumatic signs. And this is exactly what mentioned as asadhya lakshanas. Gale shopam kurute prodha, sleshmanilo shwasa lyopapannam, marmachidam dustaram metadla ahu balasa sanyam nipunaha vikaram. That balasa vyadhi, which is asadhya, is almost the same clinical features of the tonsillar abscesses, and it could be either unilateral or bilateral. A bilateral tonsillar abscess would be much more critical than the unilateral, and in these conditions, simple management with our medicine would not be enough. It is considered as asadhya, and naturally, you need to have the other support of the contemporary system of medicine. Of course, with the protocols of the contemporary system, I am not going to deal with that. So I will be minimizing that. Just suggestion that it needs that these contemporary signs. And any case of tonsillitis, if the patient has a rheumatic signs like joint pain, which is or maybe a fleeting joint pain, tachycardia, audible murmurs in the cardiac area, or chorea, that in movements, irregular movements, that they are considered as rheumatic signs, and that again you have to be careful. A tonsillitis may not be, and there the possibility of cardiac involvement in due course of the time is a major risk, and there you need to have the follow the current protocols of the treatment. Now, some more of the variations of these patients with the throat congestion, or which may mimic that tonsillitis, may not be the exact tonsillitis, could be where the patient may have swelling in the throat. Either it could be herpesgioma, sudden occurrence. Typically, that could be sudden occurrence of that herpes variation. The swelling could occur, which is somewhat common, and these are kshiprogama, kshipravidahapakaha, tivrajuraha, pittanimitajasya, Sloto nirodhanyapi mandapaka guvi stirata kapasambhava, kafaja rohini, kanta rohini, kafaja rohini, where the patient would have that sudden episode of the eruptions which are painful, and usually these are short duration. These do not last for long duration, but during short duration, patient would have more pain and the typical appearance would be multiple swellings are seen. It's not limited to the tonsils. It may even the whole palate area, posterior pharynx also could be involved, and this can be easily managed with the Kamaduka and Paripatavakata, Pittaja or Kapaja variety of the lesion. Then another of the variation which may be seen are the candidiasis, fungal infection, often which occurs in the patients with the HIV or diabetes patients, where you will have more thick discharges, foul swelling discharges, sticky discharges, or even the ulceration seen, where it's the Vataja Rohini Lakshana, Ifam Samantat, Drishabedanaya, Mamsankuraha, Kanta Nirodhini Styo. And these conditions can be managed with the Gandhakarasayana, Khadirarishta, Triphala Garbri. But if the patient has any other systemic illness like diabetes, very often it's due to diabetes, patients with the malignancies, patients with the HIV conditions, these tend to occur, particularly with malignancies where the patient is under chemotherapy. These complications are quite common, and those conditions have to be managed separately based upon the other conditions. So any patient with the candidiasis, you need to rule out any other immunocompromised conditions. The other possible complication, other condition which may mimic the same could be the tumors, carcinomas. Carcinomas are either Kantashalukas, cholestomata, where you may have localized palm swelling either at the tonsillar area or in the peritonsillar area or in the posterior pharynx, which may even have a bleeding, the fragile tissue. These are incurable, asadhya conditions, and these conditions, simple allergic treatment may not be enough. You need to follow the contemporary protocol of the treatment. I am not going to deal with that contemporary protocol of the treatment now, so I leave it as such. So that's about one stage of the disease. Now, one stage level lower, coming to one step lower, when the inflammation is involved in the larynx, involvement of the laryngeal disorders, and among them the laryngitis, one where the typical presentation would be patient would have fever, which may look like fever, common cold-like conditions, but hoarseness and malaise, the hoarseness of the voice could be quite significant. Many times the patient's sounds would be less audible, not at all audible as such. In these conditions, you have to examine, maybe simple examination with the light may not be enough. You may have to use a laryngoscope to look at that area of inflammation. Whereas lesions of the tonsils can be seen with a simple torch, and you don't need any specific investigation. For a laryngitis to make it visible, you may need a laryngoscope or a good tongue depressor so that you can visualize that area. That area of larynx visibly can be seen to be inflamed. And that again, a typical laryngitis where the patient would have the swarahani. Swarahani is a major symptom, and it's due to Shleshmruddhani Lagasi Shushka Kantaha. That typical feature of irritation in the throat would be there. At times, the patient also may have some dry cough-like symptoms. My prescription of the treatment is Mrityunjaya Triphalagukulu Antarishta. And laryngoscopy is a must if the symptoms persist beyond 3 weeks. So initially, I would be trying that patient with our medicines. If it doesn't yield in 3 weeks, then laryngoscopy is a must. And there could be other severe underlying pathology like tuberculosis, tumors, etc., which need a different protocol of the treatment. So investigations would be necessary if the patient doesn't respond in 3 weeks. Now, that further course, what happens, I will not deal with that now. Another variation or another complication of the same could be inflammation descending down into the trachea. And in that condition, the tracheitis, where the patient would have a sound during the inspiration. It's not wrong. During the inspiration, you will be able to hear the sound from a distance. Wheezing like sounds could be seen. And the patient would also have a respiratory distress, cough, very severe cough, but non-productive. The sputum doesn't occur. And systemic symptoms can occur, and that's exactly the features like Kaset to Shushkam Swarabheda. A Shushka Kasa with the Swarabheda, that's exactly the symptoms of the tracheitis mentioned there. And these are the typical features of the Pittaja or Kafaja variety of the Kasa. Hrichangam Udara Pashashuri, Shamana, Shina Parastroja, Pusakam, Anta Kapamirana, Kaset, Shushkam, Surabheda, Kafaja Kasa or Pittaja Kasa can present with the similar symptoms. And my prescription in such conditions would be Mrityunjaya, Sutashekara, either Laghusuta Mishrana or Sivapaladhi. Laghusuta Mishrana when the patient has more Kapha Lakshanas, Sivapaladhi when the patient has more Pitta Lakshanas, like the Guru Vidaha, Jwara, etc. Or Somasa and Pipadasa, again on the same lines, like either Kapha Lakshana or Pitta Lakshana. These and the duration of the treatment would be around 2 to 3 weeks in such conditions, and the warmth, patient has to have a warm exposure to the steam and so on, which can help that. Now, a slight variation from that, another one level down, would be when the trachea, it tends to involve into the trachea further distal areas, lower respiratory areas, tendency to have the bronchitis. Now, in a typical standard contemporary textbook, you do not have this kind of stage of a tendency to involve lower respiratory tract or a moderate bronchitis. But I would be making this as one stage, like one extra stage, early bronchitis like condition, which I would be considered as the Vata Kapha Jwara, where patient may have the systemic symptoms like the fever and that total body ache and so on, and typical symptoms like a Pratishaya, the nasal discharges, Kasaha, more prominent cough, and the cough tends to become more severe, more mild, much more severe than the simple cold-like conditions. Occasional crepitations or rhonchi could be audible there, and these are considered as Vata Kapha Jwara. And my treatment would be Mrityunjaya, Tribhunakirti, Talisadi, Pipalyasa or Kumaryasa based upon the Agni. If the patient has Agni Manda, I would prefer Kumaryasa. If the patient has proper appetite, then Pipalyasa is the usual prescription there. And this with this you can manage. And of course, the other part like warmth, exposure to the cold or the steam also could be useful. When the same becomes established, where you may have more crepitations and rhonchi, both audible, sputum is thick, and the symptoms are very prominent. That's the exact bronchitis, as defined in REX, where you have fever, thick sputum, and radiologically also, X-ray also can show the presence of the signs of fluid, the accumulation of the fluid, as such, where you'll have that dots, whitish dots like appearance. These are like appearance seen over the area. And that's exactly the features of the Kapha Kaphajakasa or Dundvajakasa. Shirorujarta Kapha Deha, Adhakta, the patient would have reduced appetite, systemic involvement would occur, and the typical appearance of the patient would have thick scanty expectoration, crepitations are a must as such, and radiological signs also are positive. X-ray would be necessary, and radiological signs are these fine dot-like appearance could be seen, congestion signs could be seen. And in these conditions, the duration of the treatment will be at least 2 weeks. And my prescription will be almost on the same line, and steam inhalation. The only issue is in these conditions, the duration has to be longer. Patient has to take rest, and the diet and other precautions are quite important. Acute bronchitis. At times, a patient may have the bronchitis symptoms suddenly occurring without that previous stages like involvement of the upper respiratory tract. See, a good number of patients of bronchitis would have a previous history of upper respiratory infections, which descends down. Upper respiratory infection descends down into the lower respiratory tract. But a few of the patients may have directly the symptoms with the lower respiratory without that identifiable upper respiratory tract. This I would consider as Pitta-Jakasa, and there again, the treatment protocol would be the same, but there is no need of confusion. The other clinical symptoms could be same. The only issue is the whole course of the disease is rapid, and the sputum could be more, the systemic temperature could be higher, and the toxic signs also could be higher, and that's I would consider as a Pitta-Jakasa, the acute bronchitis-like conditions. Or a chronic bronchitis, a bronchitis may tend to have become chronic, where the duration is more than a week or so, and the expectation becomes thinner and more crepitations. Crepitations becomes more, and the patient also would have the respiratory difficult dyspnea. This is another variant of the bronchitis which you can see, where you even see these vascular markings also could be prominent, along with the kyselic appearance of the X-rays, the appearance of that dot-like appearance seen, and the vascular markings become more prominent. And auscultation rhonchi also are seen. Inspiratory rhonchi also are presented along with the crepitations. That's the tamaka acid, involvement of the tamaka shwasa, kasa becoming shwasa. And tamaka kapakasa to saturate pitanabandha, pitakasa kriyam tattva. In that condition, again, the treatment would be as that of the pitakasa. And my treatment almost would be same, but in this, instead of simple Lagasuta Mishana, I would be adding Makaradharya because of the chronicity, and the duration would be minimum 3 weeks. So my prescription would be usually Nrityanjarasa, Makaradharya with the Lagasuta Mishana and the Madhuyasti. LS Mishana is Lagasuta Mishana. Lagasuta Mishana is Talisadi plus Lagasu Shekara. And with the Somasa, this is the usual prescription I will be preparing, and with that, the patient can have a better relief. Now, another variant of the same would be recurrent bronchitis, which are also may be considered as chronic bronchitis occasionally. Patient may have a history of bronchitis which is treated either with antibiotics or with our treatment, and then the patient may have repeated recurrence. Even mild exposure can result in the repeated exposure. And this is also the typical presentation of kapha purvaka shwasa or kapha just shwasa, where patient would have repeated episode of the cough and fever, breathlessness. Crepitations with the rhonchi are quite common. Radiological evidences that could be more of vascular markings, and the fibrous markings could be very prominent as such, and the even air entry could be seen to be irregular. You may have many areas of slight consolidation also may be seen. Occasional spotty consolidation could be seen, and this is a situation where the rhonchi would be more prominent. Biphasic rhonchi could be seen, and I would be preferring to use, it's a variant of the shwasa, and my prescription would be shwasa kuthara, arogyavardhini, makaradharya, Lagasuta Mishana, same, Madhyasti, Somasa. Duration would be 1 month. And once the patient, particularly in children, if the patient has crossed over the episode, to prevent another episode, I will be giving Kumari Asava as a stimulant for the Agni. That Agni Mantha has to be treated. With that, another episode can be postponed or prevented, and then the course can be avoided. The one more of the complication of the same, when the patient has repeated episodes of the cup with expectation, may result in bronchiectasis, a very chronic condition, where the patient would have persistent symptoms of more sputum, often purulent, and there is a typical postural drainage. Patient would say that the expectation is more when the patient lies down on the opposite side. So if the patient has a bronchiectasis on one right side, when the patient lies down on the left side, there will be more sputum flowing through. Sputum would be purulent, pus-like, and these are the typical features. And when you look at the X-ray, that beehive-like appearance is characteristic. Radiological evidences of involvement of the lung tissue, where the lung tissue becomes collapsed, the fibrous tissue markings become more prominent. Coarse crepitation, leathery rails are other clinical signs seen in the bronchiectasis, and that's exactly what you see in the Kshatraja Kasa, as mentioned in Vagbhata, where that the coarse crepitations are so loud, like Paralta Iva Pujan Patashuli. That patient would, that crepitations would look like or heard like a pigeon sound as such, and it could be this sputum would be purulent, which will have multiple colors like Pitam, Shavanta, Shushkam, Garditam, and so on. That symptom would be there, and this is a very chronic condition where the outcome would be quite difficult to predict as. Patients also may have a similar conditions where there could be systemic involvement of rheumatoid arthritis, cystic fibrosis, HIV, etc. So a patient with bronchiectasis is important to rule out the other conditions too. And the management also would be depending upon the other primary conditions. If the patient have these primary conditions, they need to be treated as such. But palliative treatment, there is no question of a cure in case of bronchiectasis. The palliative treatment is the only choice, and my prescription would be Mrityunjaya Swarnamani Vasanta for 1 gram with the Lagasuta Mishana given for 1 week, and this can be repeated continuously administered, and the Pushkara Mulasava and Vasaka or Vasakasava could be the other options of the treatment depending upon the presentation. Viretin is one more of the options of the treatment, but outcome is poor. It cannot be completely cured. The only thing is it can be managed better. Patient's life can be improved. Quality of life can be improved, and the repeated episodes could be reduced. Severity of the repeated episodes can be reduced. That's exactly the clinical features of the Kshadaja Kasa, or exactly the same feature mentioned in Sushruta. Bhaksho Atimatram Hridayasya Vyayam Bharabdyan Shekaihi Gatrashula Juragaham Pranakshayam Chapuradhetakasi Shushyan Vinischivati Durbalastu Prakshinamantha Rujiram Sapuyam. And this is a Siddhoshaja Lakshanas or Kshayada Kasa also. Now, one of the important measures by which the patient can feel better would be facilitate the drainage. So airway clearance is one of the important measures, more than the medical management. In case of bronchiectasis, airway clearance technique is one of the important issues. Airway clearance technique is the patient has to bend forwards and then has to press upon the abdomen or hold the breath and then cough violently as such. That's somewhat like the Bhastrika Pranayama. And Bhastrika Pranayama practice in such conditions helps a good resolution. Now, the one of important steps in that condition, bronchiectasis, would be to ensure that the accumulated exudate is expelled out. And this exercise would help in expulsion. And I always advise the patient to practice these techniques. And this can help a lot. At times, it could be more than the medicines that these techniques could help us. So that's one way. One more of the presentation which can occur in the respiratory conditions can be a consequence of the descending inflammations, or at times it could be occurring all of a sudden. That's pneumonitis, where the whole inflammation involves the lung tissue and the patient would have a consolidation. The lung tissue would be having the consolidation. Typically, the pneumonitis presents with the stages. The first stage would be high fever, pain, and there would be non-productive cough. That's the stage of consolidation. The next stage would be, there would be more productive cough. The patient would have more sputum. That's the stage of resolution, which occurs like, or stage of liquefaction occurs. And then, of course, in a usual consequence, there will be a third stage of resolution. So second stage is of the liquefaction, where the first this sputum would be produced. There will be more of sputum produced. The first week would be high fever, chest pain, and dry cough is the first week. Second week, there will be a more productive expectation. Typically, on auscultation, there will be bronchial breathing as such, and raised leukocyte count is one of the important signs. X-rays would help. Radiological signs would be the signs of consolidation in that condition. And it's considered, I would consider it as a Vishama Jwara as such. And I would be treating that patient would be Mrityunjaya or Lakshminarayana in the second week. If in the early stage, first stage, it's the Mrityunjaya Kapha Jwara. And then the Vishamadwara, when the condition becomes more, it's Vishamadwara. That's I would be preferring Lakshminarayana, sir. Makaraja is the same as the usual protocol. If the condition has presenting with the more of the leukocyte count, antibiotic therapy, if the total count is more than 16,000, I will be preferring antibiotic therapy in such conditions, particularly in children. And a pneumonia accompanied with the other diseases, pneumonia in children can result in more complications. Now, another real difficulty in the clinical situation is a non-resolving pneumonia. A standard protocol of pneumonia, the pneumonia should resolve in 3 weeks. But you will have plenty of patients where the pneumonia may not resolve in 3 weeks. It may persist beyond that. And there you need to have very elaborate diagnostic workout. And a underlying pathology could be at times it could be very severe. So I will not go into that detail now today. But one precaution is, if you are not able to have a clinical resolution of pneumonia in 3 weeks, then that patient has some other serious underlying pathology which needs to be evaluated and which needs more effective treatment. It could be very severe pathology. There could be an abscess there could be a foreign body left over in the lungs, it could be a tumor pathology, and so on. So all that has to be ruled out, and you need to have a series of investigations. But I think I will not go into that in today's issue. Now, pneumonitis, the same clinical features would be the same as mentioned in Sushruta. Then another of the variation is the obstructive lung pathology. or chronic obstructive pulmonary disorders, where the patient may have a respiratory difficulty, Shwasa, the typical Shwasa, where the patient presents with breathlessness. Now, that breathlessness or the obstructive conditions could be of two categories. Shwasa could be of two categories. A patient having a history of breathlessness persisting for a long duration is a category of two categories which are considered as obstructive or restrictive. Now, the same is mentioned in our Samhita. Samhita also says like a kaphavrata conditions are the typical presentations of the obstructive conditions where dirgham shositi, the inspiration will be longer. Yasturdo na pratyahartyada, the expiration will be shorter. The duration of expiration becomes shorter. So when you auscultate, there will be bronchial breathing, a loud inspiratory sound and low intensity, shorter duration of expiratory sound. Gap between the inspiration and expiration becomes reduced. And the patient may have shushkasya, there will be dry cough and the differences, difficulties with that. Whereas urdhashwasa prakupite, in the restricted conditions, adhashwasaha nirudhyate. Inspiration would be lesser. Intensity of the inspiration and the duration of the inspiratory sound would be lesser. And muhus tamyati. Now, this difference, the inspiratory and expiratory difference, is exactly the basic difference between an obstructive and restrictive pathology. To objective description of the obstructive restrictive pathology is can be made out by the instruments where the respiratory volume can be assessed. The respiratory volumes can be assessed with the sophisticated instruments where a typical normal breathing inspiration and a relative longer expiration is made out. In a typical obstructive pathology, the inspiration is normal, expiratory sounds will be lesser, duration of the expiration becomes longer and weaker as. In a restrictive pathology, the inspiration is shorter, expiration also comes to the same duration as such. Gap between the two becomes lesser. Now, these can be better made out with the instruments and confirmed as such. The usual causes these obstructive are patients with the chronic bronchitis, emphysema, cystic fibrosis, it could be obstructive. Restrictive is interstitial lung disorder where the lung tissue is damaged. Patients with obesity, neurological manifestations where the exercise would be lesser. The management would be, again, I would be limiting to a few of the conditions, but primarily this is important. The important is that in a case of restrictive pathology, the standard common modern treatment like bronchodilators would not help, rather would even worsen the condition. If the patient has a restrictive pathology where the inspiration is lesser, the bronchodilators, which are very common prescriptions in case of chronic respiratory pathologies, would worsen the condition. They will not help. Whereas bronchodilators can help and can resolve the symptoms in a obstructive pathology only. Now, from our clinical point of view, I would be dealing with a few of these conditions. One of the restrictive conditions which we often see is the interstitial lung disorders. Interstitial lung disorders often produced due to some other autoimmune pathologies, collagen tissue disorders, or due to the allergic pathology, a chronic allergic pathology, which can be, cause for the fibrosis in the lungs would occur. And the drugs, certain of the drugs also can produce the same. Typical history would be like the patient would have exercise intolerance. Ruksha ayasudbhava. Kshudravata. The patient would have a difficulty produced due to the exercise. That's the Kshudra Shwasa. And the patient would have a dry cough, repeated episodes with the crepitations and inspiratory sounds being less. And there could be systemic signs like club fingers, scleroderma, so on in interstitial lung disorders. And in these conditions, my prescription would be Shwasakutara, Arogyartani, Pipalyasava, and Avipratika Churna and Bogatya, Churna. That's Amashaya Bhava, and the treatment would be for the Amashaya. That's the basic treatment. Pranayama helps very significantly. Practice of pranayama in this condition would help. Virachana also is useful in these conditions. And one important is in the interstitial lung disorder, the duration of the treatment has to be infinite. Say Yapya Vyadhi, and it can manage it better with only these conditions as well. Now, same interstitial lung disorders, when it becomes more chronic and the total lung damage is quite significant, like the total volume is lesser, and the patient presents with the emphysema, typical emphysema, where the respiratory sounds would be emphysematous as such. In that condition, my prescription begin almost the same line. There would be more Brahmana Chikitsa like Chavana Prasha would be given along with the same Shasakota, Arugyatin, Makaradvaja, and the Lakasuga mixture. Virechana also is the other part, but there a more Brahmana Chikitsa like Chavana Prasha could be used as a very established emphysema. I would be considered this as the Kafo Parudagati Shwasa, where the Kafada Shwasa, where the patient would have a short breath and auscultatory findings of typical emphysematic breathing. Emphysematic breathing would be a low intensity inspiratory sound and high intensity expiratory sounds. Inspiration and expiration, the gap becomes more. And in these conditions, crepitations also could be presented in emphysema. Breathlessness is even persisting maybe during the rest conditions too. Then the main treatment would be Shwasaputara, Punarnamandura, Makaradvaja, Sitopalati, etc. And then Virechana. This is the same protocol. There is in any of these conditions, the patient may go into respiratory failure. Respiratory failure is when the oxygen level goes below 80% or so on, 80% or 78%. The protocols are different. And the respiratory failure is a situation where the patient would have oxygen level being lesser in the system. And there are two types of the respiratory failure. Type 1 respiratory failure involves low oxygen, but carbon dioxide levels are normal. And it's often produced due to diseases where the lung tissue is damaged, like tuberculosis, pneumonia, respiratory distress syndrome, etc. Type 2 respiratory failure is a ventilatory failure, where the patient is not able to breathe in sufficient volume, and it can occur in chest wall deformities, muscular or neurovascular pathologies. But this accurate differentiation of this can be done with the spirometry, blood gas analysis, or pulse oximetry also helps in making of that. So these protocols are necessary. Any of the patient presented with the respiratory difficulty, it's important that you have to identify the nature of the respiratory failure and severity of the respiratory failure. If the respiratory failure is severe and oxygen concentration is less as such, it can result in complications like cyanosis, asterixis, involuntary movement can occur. Neurological manifestations like restlessness, anxiety, confusion, seizures, coma also can occur. These are the typical of asadhya tamaka shwasa, where the patient would have prasamyati sabegana trishyate saniruddhite, pramoham kasamanasya. The patient may even have impaired level of consciousness or unconscious or coma also can occur. These conditions would be difficult to manage with our treatment alone. And one more of the variation would be acute respiratory distress syndrome. All of a sudden, patient present with the acute tachypnea and dyspnea and auscultatory findings like crepitation. Though the incidents are lesser, it can occur quite occasionally, where the patient may have a direct insult or a direct injury to the respiratory process, like lung injury, sepsis, or so on, where the typical definition of acute respiratory distress syndrome is based upon involvement of 3 or 4 quadrant of alveolar flooding. Like when the X-ray is done, you'll see the consolidation in more than 3 or 4 quadrant of the lung tissue. And the total compliance of the lung tissue capacity, inspiratory capacity is reduced, and the gas exchange will be severe hypoxia. Now, these are the conditions where the patient needs oxygen supply. Now, all the point is a simple management with our medicine alone may not be enough in such conditions. Patient would require oxygen. Oxygen has to be provided, and the oxygen guidelines. Now, again, I will not go into that very high details of this oxygen issue, but oxygen would be necessary. And there is a standard guideline of the oxygen. The standard guideline of the oxygen is a drug which needs a prescription. Oxygen is a treatment for hypoxemia in general. And in all acute unwell patients, not at a risk of type 2 respiratory failure. Type 2 respiratory failure, supplement of oxygenation would not be enough temporarily. And the target saturation, you have to provide the oxygen to maintain the oxygen concentration of 94 to 98%. If it goes below 80%, it becomes critical and it becomes a respiratory failure. And in a patient with the type 2 respiratory failure, it may not be it may not be possible to reach to the level of 94-98%. Even 88 to 92% is enough. With that you can maintain. And to maintain this concentration, oxygen delivery systems of different types could be used. You will have to get acquainted with that. Simplest will be nasal mucosa, and the more complicated would be tracheostomy column, or even the other varieties. Now, I will not go into that, the indications for these, because the same would be again a very elaborate issue. But you have to, any person who deals with these respiratory difficulties have to have an idea like how to give the oxygen, and this has to be selectively used depending upon the condition. Now, oxygen concentration being reduced or hypoxia can be managed with the supplement of the oxygen only in a hypoxia, where the oxygen supply is less. But if the patient has the hypoxia, that provision of the oxygen to the peripheral tissue is reduced due to a reduced oxygen carrying capacity of the blood, which we call as anemic hypoxia, where the patient blood cannot carry the oxygen from the lungs to the tissues, or stagnant hypoxia, where the circulation of the blood has become reduced, as in a patient of shock, or cytotoxic hypoxia, where the tissue is already damaged due to the toxic substances, like as in case of cyanide poisoning. A simple supplement of oxygen would not be enough. The patients who have a very chronic lung disorders and the patients who have a high risk of developing hypoxia, they need to have oxygen supply almost daily, particularly when the patient goes into sleep, that the respiratory efforts could be reduced. And in case of restrictive pathologies, oxygen can be provided at home, and the oxygen provision at home could be of two categories, either CPAP or BiPAP. CPAP is the instruments are available. Of course, now these days it has been quite common. It has to be provided to the patient, and this can be useful to save the life of the patient. Again, preference like CPAP or BiPAP would be based upon the presentation. Only the difference is in the BiPAP, the respiratory effort would be lesser, whereas in case of the expiratory effort would be lesser. In CPAP, expiratory efforts would be more, and select that typical instrument which could be supplied as such. So that's in briefly about that respiratory difficulties and management. But they are necessary. Whether it's not the question of whether aerobic treatment or not, provision of the oxygen and maintenance of the oxygen concentration is vital. And if you have to save the life of the patient, it's important. Now, one more of the condition which can be seen in case of the respiratory conditions is pulmonary tuberculosis. Pulmonary tuberculosis, the typical history is a chronic history, low-grade fever, thick expectoration, history of emaciation, and a typical bronchitis or cavernous breathing. And radiological signs are, now you have series of investigations to confirm the diagnosis of tuberculosis, like a sputum test or serological tests also are possible. I will not go into that part. And the patients who have a diabetes or HIV, you need to rule out that tuberculosis. And it's a typical presentation of the Kshayaja Kasa or Kshaya acid. Now, when we diagnose a case of tuberculosis, there is a issue. Now, my purpose of referring to that issue is the issue is now there is a national health program where reporting of the tuberculosis is a must. And reporting of the tuberculosis under the Nikshaya program in the Nikshaya website is necessary. And it's made mandatory. If you do not report that, it can be an offense, though it's not yet, any court has not given any punishment to any doctor till now. There was an incident of medical council acting upon a physician who has not reported. So if there is a case of tuberculosis now, you need to report the patient to the health authorities, and the provision of the treatment and health authorities through the Nikshaya website. Nikshaya.in is the website where you are supposed to report, and the treatment has of anti-tubercular treatment is made mandatory. And if at all those who are interested about that issues of legal issues related to that, you may refer to this central government release, National Strategic Plan for Tuberculosis Elimination, and it's a must. We need to follow that. Now, so when a question of tuberculosis, I would not treat that tuberculosis by primarily our treatment, but patients who are on anti-tubercular treatment, or patients who develop drug-resistant tuberculosis. And when they come over to Ayurvedic treatment, I would be preparing either Arogyarjini Kumaryasava along with the other anti-tubercular treatment. Rasayan therapy with the Chavanaprasha would be the other options of the treatment. Multi-drug resistant tuberculosis, where your contemporary system of medicine fails to produce the results, clinical symptoms can be helped to be resolved with the Lakshminarayan Rasa, Arogyarjini, Makardhvaja, and Sisopalagi, and Vasakarisha or Draksharishta, usual Kasa Chikitsa, bit more advanced as such. Now, one more of the respiratory condition is the pleural effusions, urokshakas. Urokshakas could be of different categories. One could be where the patient may have a expectoration with the pus-like conditions, where the patient may have Shate Raktam Puyaha Prolatis Gachati, where the patient may have pus accumulated, the pyothorax, or it could be like where the patient may have a Rakta Jakasa, Rakta blood filled hemothorax in case of Marmadhata, or patient may have a fluid accumulated where Kapha Costa there. Pyothorax, hydrothorax, and hemothorax. All these are defined in Sushruta in different contexts as such. And pneumothorax is where there could be air getting into the pleura, and the Vatapurna Kostadaya causes Swasabhyam Maranam. In case of Marmadhata, Apastambha Marma involvement and Lohita Marma involvement or Amsa Marma's involvement, it can result in hemothorax. Now, these are defined by Sushruta. In Sanamula Marma Apagata, it can result in Kamapurna Kostadaya. That's the same. Now, in all pleural effusions, a patient presenting with the pleural effusion, the important is diagnostic is essential. Diagnostic tapping is essential, and there is no question of hesitation of that. And more than 70% of pleural effusions seen are of tubercular pathology. And in the tuberculosis protocol, I have already mentioned. Now, if the other diagnosis based upon the other causes like pyothorax or maybe the tumor pathology, hemothorax conditions, the management will be based upon the specific causes as such. A supportive management would be Gokshadi, Punarnamandal, Pushkaram Plasa. But primary management would be based upon the differential diagnosis. But I'm not going to that issues now. I leave it as such at that point. Now, one more of the condition which can present with the respiratory symptoms, but not of the respiratory system, would be pericardial effusion, which is typical of the Shleshma or the conditions like Kapaja Shwasa conditions or Shleshma Kapaja Hridroga conditions like Shleshmana Hridayam Stabdam Barikam Sashmagarbo. Now, Kasa Agni Sadhanishtiva Nidra Arasir Aruchi Jwaraha. In these conditions, the confirmation of the diagnosis is important. You may need echocardiography. Simple X-rays also can help you to make out the diagnosis. But important is a patient presenting with dyspnea need not always be produced to respiratory system pathology. There could be cardiac pathologies, many other. Now, I will not go into much of the other issues, congestive cardiac failure and so on. But I just give one example, pericardial effusion, which can produce a confusion with the respiratory symptoms as such. And in these conditions, you need to treat that patient based upon the condition, and general palliative management, which I would prefer, would be Prabhakaravati, Punarnamandura, Punarnavasa as such. That's the treatment. Of course, congestive cardiac failure is other condition, which also can present with the respiratory symptoms. That again, the clinical diagnostic protocol has to be followed. Treatment protocol also has to be followed in detail as such. Lung carcinomas, malignancies of the lungs also can be presented with the respiratory symptoms, and the symptoms could be of different categories. Cough, weight loss, dyspnea, chest pain, hemoptysis, pain in the bones, clubbing, fever, weakness, so on. Now, these again require a more elaborate clinical diagnostic approaches. So a patient of respiratory difficulty needs all the diagnostic approaches, which could be even the bronchoscopy or maybe CT scan, MRI scan, and so on. So again, considering the limitations of the time, I will not go into that detail. But one word of caution is every patient presenting with the breathless is not Shwasa, or simply a management of the line of Shwasa would not be enough. All the investigational protocol would be necessary. And of course, even a patient is made of a diagnosis of carcinoma of the lungs, The basic treatment protocol would be based upon the contemporary oncological practice. The only supportive treatment is suggested, and my supportive treatment suggestion would be Arogyadri Kumaryasava. I would not treat that condition primarily with Ayurvedic treatment alone. With this, let me conclude, because I think I have covered a bit more time, and there should be some time for question and answers. And hence, I will conclude. And conclusion is, Ayurveda has significant advantage in selective patients, and you can definitely have a edge in the diagnosis, a specific area in the society where practice can be defined and developed by Ayurvedic practice. One of the important issue is interest of the patient has to be saved and has to be protected, and clinical diagnosis and prediction of the course is crucial. And in a large number of patients, more than the medicines, the lifestyle management could be quite useful and can produce the output. With this, let me conclude, and I would like to see if there are any questions asked. There are some questions, no? There are no questions till now. So if there are any questions, I will try to answer and then wind up. And thank you again for patient hearing.
Thank you, sir, for such an informative class. Now the session is open for question discussion. Audience can raise their questions either by unmuting yourselves, or you can raise the questions in the chat box.
Okay, there are no questions, so I think we can wind up. Okay, then thank you. So.
A sincere thanks to you, sir, on behalf of everyone. We have discussed about the very basic elements of Ayurvedic management of respiratory disorders. A class across it as dealing respiratory system disorders stepwise, starting from basic and most common respiratory ailments, in the different stage-related treatment of many disorders, including allergic rhinitis, and so on. Once again, I express our sincere thanks to you, sir,
Okay.
and to all the participants. This was the last online session of Anahata, and thanking every participant for joining us and cooperating for the same. So that's it. Thank you all. With this, we officially conclude this session.